Strategies for Asia, hosted by IMU International Medical University as part of a celebration, 10th year celebration of School of Dentistry. So we have two sponsors which we have to acknowledge. The first sponsor is QNM, and QNM who have been a primary sponsor with dental care facilities in a lot of places. And the second sponsor is Cavo Care. Cavo is a good name which we are all familiar with. And thank you for it. And now we have three speakers lined up for us. Is Dr. Irene from India. And now I'm really excited to present my next speaker, Professor Rahima Abdul Khan. She is a famous personality in Malaysia, and she did the DDS, MSc, MPH from Michigan, DRPH from Michigan, FICD in USA. She was the founding dean, Faculty of Dentistry, and professor and senior consultant in DPH, Preventive Dentistry, Lincoln University College. Before Lincoln, she has served in and has been responsible for the starting of the postgraduate course. So for the past 40 years, she served University Malaya and University Kebangsaan, Malaysia in various central and faculty administrative educational capacities, government and professional consultative positions in Malaysian Dental Council, in Malaysian Qualification Agency. Malaysian Qualification Agency, for your information, is the agency which says to us that our curriculum is fit enough to produce a good dentist. And she is an important member in that, and internationally as chairman of Malaysian chapter for ACSF. Her expertise is not is not limited to clinical prevention and dental public health, oral epidemiology, dental education, curriculum development, tobacco cessation practice and research. I am making her introduction short so that we can go on to the presentation because it runs through so many pages. Thank you, Prof. Rahima, for being with us, and let us hear from the leader on dental leadership.
Okay, just go on. Thank you very much for your very kind introduction. I think it is a little bit overboard. I'm just a simple person. Yeah, and I'm very happy to be here with everybody. I would like to actually, I won't be going through all the theoretical leadership. I was asked by the organizers to share my 40 years experience working through the pathway of working to where I am today. So I think it will be a kind of a light entertainment and info kind of thing that I would like to share with you. Because what was yesterday's, how do we look at our role yesterday? What is going to be our role today? And what are tomorrow's challenges? I think this is values and that people need to know, especially the young dentists, particularly if you're going to move on in the world. And as we've heard, Prof. Gallagher was saying about the need for managing elderly population. Prof. Patip was talking about all the important things about where you are going to move on. And we have even a question being asked, if it's a stable population, what is going to happen for the emerging dentists? So let's share with you what I have in mind. Okay, as we move on, I have to move it. Okay, I would like to just discuss this over three landscapes. This is yesterday's role, today's needs, and tomorrow's challenges. Okay, let's see. I think it's very, very relevant, not only in Malaysia, but also in many other countries, particularly in the Asian region and the developing countries, where you see this scenario yesterday. In many countries, we have lots of oral disease prevalence. We have high disease prevalence, especially dental caries and periodontal disease. This is the most basic. We have high burden of illness. We have high treatment needs. We have low-level treatment provisions. I mean, mostly things done mostly about extraction, simple fillings, scalings. And we have in those times, in most countries, we have few formally trained dentists. Whatever trained dentists we have, they are very technically focused. I mean, you are doing the job what you're supposed to do. And around that landscape, we have also 4 facilities. So the survival rate of all the dentists in those times were very, very high. They were, they hardly, as I remembered, we have to treat hundreds a day, and, we even have little time for ourselves. Yeah, but the landscape today probably may have changed. So in those time, if you look at that time, for just take an example for Malaysia, for example, and the Southeast Asian region. Today we have approximately 100% of all the adults in the world, and 60 to 80% children worldwide, they are still suffering from tooth decay. And despite the fact that we have so many oral leaders today, why are we having this problem? What's wrong with us? Are we not moving on in the way we manage patients? I think we have gone with so many new techniques, new materials, so forth. And you look at Asia, Southeast Asian region, where 87% of the population are still having caries. That's a lot of caries on the way. So you don't have to worry, our young dentists, if you are calculating by the what do you call this population needs to the dentist population ratio, you actually, if you calculate the number of teeth that you are treating, not just the body, you'd have lots of diseases to cover, and you don't have to worry about not having a job in future. I can assure you, you have lots of it coming up. And of course, and if we are so, in those times, our dentist role, actually, if you're a leader at that time, or I would say more a manager, very simple. You build and open clinics. You organize provision of treatment to sort out the major oral diseases. You develop relevant manpower, particularly if we are in the government sector or any organization for that matter. You including opening a new dentistry faculty. And service is for all, especially the vulnerable population. So it's a non-issue. Everybody gets treatment. And as we move on, that time, if you happen to have a managerial role, actually it is by chance. You are a coincidental builder. You put on the job due to unavailability of many technical professional experts in the organization or the country at the time. And more than often, when you're doing the job, you're really a novice to management. That's why I had to go through. It's a trial and error thing. Yeah, and no questions asked. You've got the kind of mentors and bosses whose style says it all. Do as I told you, or no, you have to get the job done. Or do as I do now, exactly. And just trial and error, nurturing kind of thing to say that try this. And you are actually working in silo among your kind. That is how I think at those times that is okay. But today, whatever you have done those times, the outcome is no matter what, you actually get the job done. It's functional and operable. Bosses are happy. Simple-minded clients too are very happy. But yesterday leadership style, as we can see it, is in three forms. They are cohesive leadership, as I said, do as I told you, or pace setting, do as I do, or coaching, nurturing, a trial and error. Those are relevant, again, as I mentioned, in times where we don't have much. Okay, now, but as the world goes, time stops for no man. So we are seeing today a different kind of landscape, a different scenario where you see a rapid, vibrant development and modernization, even in Malaysia, where the society has become affluent. Yesterday, many years ago, 40 years down the line, when I graduated out as a dentist, there was only 7 million population. Today we have all the infrastructures, all the beautiful things, and we have now 29 million population. Okay, so on top of that, what we are also seeing, not only the change in the infrastructure, but we are also seeing the change in the population. So we are looking at changing lifestyles and demographic character of a particularly young population, because Malaysia has 38% below the age of 20 years old. And I think I read that Prof. Gallagher says you want to do a projection, you need to know the demographic character profile of your population. And the population is different today. These young people or even the young workers, they have increased life stress, they have low pain threshold, they have peer pressure influences, all the imported detrimental habits that we do not want in around our region, and of course sugar and acidic food, which is the, everybody tells you, don't eat too much sugar. And on top of that, we are seeing more and more with all these beautiful ladies being the queens of so and so. We have vanity coming in among the girls. We have anorexia. We have bulimia. So if you are looking at just simplistically, looking at even treating the individual patient, it may not be so easy today. Okay, and what more if we are looking at the whole population? We are looking at the population, like for Asians, for example. Asians are very famous for eating. Yeah, they eat more than they should. And how many times a day? At least 6 times a day. Look at the times they say. So every time my colleagues come from over the, across the other continent and look at the way that we are eating, they just get the shock of their life, you know. But we enjoy it. So what can we do? But if you're talking about, and as what they call, if you're just treating the patient and saying that to reduce the sugar and to do the, do you think you're going to be successful? Or if just what they call our oral health division, for example, we just focus on just working around that sector among the oral health workers, are we going to be successful? I don't think we are going to be successful because we have this to cover. The influence of the industry. Who is going to tell the industries they should not be doing this? Who? As far as the industries are concerned, it's about dollars and cents. But as far as we are concerned, we are trying to reduce the burden of illness. So we seems not to be working in tandem with each other. And of course, then having said that, to me, sorting the problem requires multi-sectoral involvement. We have it there. Oral health promotion says it all. Even the primary health care model says it all. But are we practicing it? So we need to look into three things probably. Developing and refining issues because we are going to be involved. So we cannot just say, I just know, it's okay if I know how to do this and this clinically. But you need to be open up your mind. You need to look into the policy issues. You need to look at the manpower issues, especially if you are appointed as one of the managers. You look at the social issues because how are things going to work? Environmental issues, financial issues, service quality issues. There's endless issues today. It's different from what we had many years ago. So there is a need, therefore, for interagency collaboration within and with outside partners. But are you ready for it? Are we training the students for this to be the future leaders that know how to do this? We have to ask ourselves. And then we talk about professionalism and compromise without sacrificing quality and integrity. We need to work with people, but we need to remain professional. We should not be giving up or giving away up to a certain level, yes, but not overly kind. Sometimes we hear the word, it's better to be unkind than to be overly kind. Yeah, so we have to look into this matter. So this is what we are worried about. Are our next generation of dentists or future leaders ready for this kind of scenario? So ask ourselves, do we need more expertise? Do we need more advanced technical procedural skills? If you're a specialist, you already have it. So what else do you need? Perhaps you should relook at the way that you are going to be one of the oral health leaders, as Dr. Lee was mentioning. I am one of them. I'm not sure which group of SDL I was from. I've forgotten. But yeah, you need to look into this. Do you really need to do a lot more or going to a lot more of all technical skills? Or why don't you just leave it to the others, the younger ones, but maybe you upgrade, you advance yourself to all the other expertise that is needed to become a leader. As in terms of collaboration, being a dental leader is not so easy. I'm giving you an example here. We have in Malaysia a national agenda today. We've just finished the capacity building, what they call this workshop. Actually, to be honest with you, I'm not working with dentists here. I'm working a lot with a lot of people here who are not dentists. They're medical doctors, they are social scientists, they are, I don't know what have you. And what we end up, because our main objective, if you are leader of tomorrow, you have to go for the goal. The one goal. What is your goal? It's about professionalism. It is not about you. It is about the how you are going to get that goal in hand, and then you are going to work with everybody. How have we prepared our young dentists to meet that? Okay, so this is our mission and game. We are hoping by the year 2045, we would have reduced to 5% of those tobaccos. It may look almost like impossible. I can tell you why, because we have been working, actually, when they started this, they have been working in silo. Okay, when the Ministry of Health started this, I would say that they are working in silo. We have signed the signatory what they call with the FCTC in WHO, and we have actually a one that is functioning in Malaysia. But as I said, they were working only among the health sector. But today, we see that there's a need. If we're going to reach that goal of the end game, it's not going to happen if just the medical doctors are involved. So we are now working with so many people to try and make it in order to reduce the smoking prevalence that we are seeing today. This is the picture of our current smokers, and it is not a very nice picture. In fact, we are worried now because the ladies are on the increase to become smokers. So, and if you look at this, unfortunately, we don't seem to have it improved in terms of the number of smokers over the many years. From 1996 to 2015, it looks to be like stationary, almost stationary. If there's any decrease, it's very minimal. Recently, as I said, we decided that we need to work in collaboration. So I'm one of the members of the research group of University Malaya under the nicotine research group, and we brought in Professor Judith McKay, and we had this to think about building capacity in this, and who are the people inside there. You won't believe it. There are as many dentists as medical doctors, as social scientists, as government people, and even in the industry. So, even we have a journalist inside there. So, you see, this is what we need today, tomorrow. Today is the need where we need to do a lot of collaboration if we are going to settle any of our own problems, be it caries or periodontal diseases. Leaders need to learn about how to collaborate with other people. Open your mind and work on it with other people. Because when you work, this is what we end up having now. We build trust, we build sharing ideas, and today we see what we don't see many years ago, a working collaboration of many partners, not only government agencies, but also the university, the NGOs, as well as the industry. So on this ground, we are hoping and we are very optimistic that we will probably reach the end game of tobacco control. Another area that a lot of people, we are talking about oral health here. I have been working on the indigenous population. And this is a unique population in Peninsular Malaysia, where we see that they will never come to the clinic, regardless whether they're dental or medical, even though it's just across the road from their settlement. So what we have done a lot of research, and they are one of those with a high burden of illness. We don't have any information on them, but what we have been doing at those many years ago, and it started off with the 1999 collaborative study with me leading the group, because I was appointed by the government to lead the group with an Australian university, Australian National University. We have our what they call museum, National Museum, and also the Department of the Orang Asli, that's the indigenous, where we actually go into all the villages in the remote areas of Malaysia throughout the. It would not, it seems to be impossible. It was very, very difficult for us to work on the Orang Aslis, to be honest with you. If we had not had this good collaboration, the museum people actually do the scouting for us. They do the aerial scouting and they find a way to get into the jungle for us. And we, the Department of Orang Asli leads them and also be our translators. And both me, our team, this is dentist because we are looking for the origins of the Orang Asli as in relation to Australian indigenous. So the two of us, we actually be on standby, and every weekend we will go into the jungle because the museum people would get us, and we are there for the whole 3 days or whatever days that we are supposed to be there to do the examination, screening, and all the qualitative studies that we do. It would not have been possible without together. So that has been the gateway to many other studies where we're talking about the more modern one. We developed because, as I said, they will not allow us to enter their house. They will not want to work with us. They will still go to their main healers. So we then train with the Johor State Oral Health and Medical Health. We train, we develop a young Orang Asli advocates. They are the one who goes to the house. We do the TOT, and we actually ask them to go to the house and they collect all the information for us and even do the promotion to bring them out of the house to the clinic. Okay, so the successful venture requires leaders of today to brave out uncharted waters and move out of their own comfort zone. You can't be sitting behind the desk nor behind the computers. You have to be on the ground. I'm still on the ground until today. Okay, if we are looking at this picture, there is a need for transformation, yeah, of all of us, whether we are managers, and more so managers can turn to be, in the end, to be leaders. We not only be as initiators, planners, and implementers of project, but to also have other business-like features and skills. That is a need. Change of attitude is number one. You need to be more open-minded. You cannot be talking about the cavity alone. Okay, to want to learn and relearn always and transform them to new ideas. Character building is another issue to be held, to be given to especially the young ones, to be strong in the art of persuasion and negotiation. You need to persuade and you need to negotiate, not only with your patient, but more so with your partners in any project for that matter. You need to be provided with opportunities to give to them. You have to have excellent communication skills. We've heard this many times. We need to have good digital and data information skills, and we need to be knowledgeable on research finding as to be able to prioritize based on evidence available, and we need to be objective and smart in dedicating work. Therefore, that's why we have key performance index. All over the world, we have key performance index. We'll never get the job done unless we have this kind of thing. So who best meets tomorrow's needs then? Managers or leaders? As Dr. Lee has been saying, management is doing things right. Leadership is doing the right things. So we need to ask ourselves, if we are still managers, we still have a chance to be leaders of tomorrow. But if you are leaders, you need to work harder, so that to help other people as well. And the bottom line is, the leaders, to me, if you take 2 cups of authoritative leadership, 1 cup of democratic coaching and affiliative leadership, and a little bit of pace setting and cohesive leadership to taste so that it is not so blunt or sour, and you lead based on need in a way that elevates and inspires your team, you've got an excellent recipe for long-term leadership success with every team in your life. With that, I thank you very much for your patience, and I would welcome any questions available. Thank you.
Wow, Prof. Rahima. It was excellent, mind-blowing for me. Now I know why everyone says your name in awe. Thank you very much. Allow me to praise our speaker from Malaysia for an excellent presentation. She has told how a dentist as a leader can make a vital change to promote oral health and reduce the burden of oral health. And one aspect should be encouraging for the cigarette companies, where you mentioned that ladies have started to fall into the trap of smoking. So maybe we should also get it away from them. Thank you, Prof. Rahima. It was an excellent presentation. We'll have the Q&A session after all the speakers are finished speaking. And now it's the turn of Prof. Kallam Durward. Allow me to give him access. And Prof. Rahima will be cutting a video so that Prof. Kalam can come online. And then for the Q&A session, all the speakers will be online. Unfortunately, Dr. Lee couldn't join us, but it is more than compensated by Prof. Rahima, Prof. Kalam, and Dr. Irene from Indonesia. So give me some to get Kalam on board. Yeah, we have Prof. Kalam on board. Allow me to introduce Prof. Kalam. He's in Cambodia, and he's Dean, Faculty of Dental Sciences, Dentistry, Faculty of Dentistry, University of Puti Sastra. He has worked in the public system and academic institutions in New Zealand and Asia, particularly Cambodia. He is actively involved in a number of research projects, mostly related to oral health in Cambodia. His expertise is on pediatric dentistry and dental public health. He will talk on dental leadership in the perspective of Cambodia. Now, over to you, Prof. Kalam. I'll move away so that you have a good presentation. Thank you.
Thank you. It's a great pleasure to be here and to join you.
Good afternoon, everyone. My name's Callum Durwood. I'm the Dean at the Faculty of Health Sciences at the University of Puti Sastra in Cambodia. Today, I'd like to speak about leadership in dentistry in Cambodia. I originally come from New Zealand, and about 10 years ago, I moved to live in Cambodia. My history with Cambodia goes back a long way, as in the 1980s, I worked in refugee camps along the Thai-Cambodian border, and then came to live in Cambodia for 2 years in the early 90s. What is leadership? There are various definitions of leadership, including this one from the Oxford English Dictionary: the action of leading a group of people or an organization, or from Webster's Dictionary, the power or ability to lead other people. There are many personality characteristics which have been found to be reliably associated with leadership emergence, including the things listed here. There's a wide range of characteristics that we can identify. One of the questions that is always asked about leadership: are leaders born or made? Well, it is believed that people inherit certain qualities and traits that make them better suited to leadership. However, others believe that people can become leaders through the process of teaching, learning, and observation. Leadership is a set of skills that can be learned by training, perception, practice, and experience over time. Good leaders are known to seek out development opportunities that will help them learn new skills. The best estimates offered by research is that leadership is about 1/3 born and 2/3 made. But leadership in Cambodia has a historical perspective. During the Khmer Rouge years in the 1970s, there were genocidal leaders, alternative leaders, or others who questioned the leaders were executed. Following this period, new leaders emerged under the communist regime. Those who had served the party well had the best chance to become a leader, and almost all of them were men. Many have retained leadership positions in government today, which is still very male-dominated. Let's talk about the development of dental leaders in Cambodia. Only 34 dentists remained after the Pol Pot period. Many were put in leadership positions to run dental services, hospitals, the dental school, and so on. But these were very challenging times. There was a lack of resources, and dentistry was a low priority. In those early years, some Vietnamese leaders came to help train the local Cambodian leaders. Leadership in dentistry in Cambodia today is what I want to focus on. Many of the old dental leaders have now retired and been replaced with a new generation of young, dynamic leaders. Many are female. Many have received higher education overseas. And although some are political appointees, most are leaders because of their own ambition, talents, hard work, and vision for a better future. Here are some examples of Cambodia's new generation of leaders. Today I want to share some of these dynamic leaders with you, and I want to point out what qualities each has that makes them a good leader. Today I'm going to introduce you to Dr. Yam Solita, Dr. Sher Tepiru, Dr. Kor Hok Sim, and Ms. Sieng Tida, all of them women. So let's start with Dr. Solita, the former Cambodian Dental Association president. She has shown as a leader excellent communication with dentists, government officials, and international bodies, such as the FDI. She's also shown courage to speak up on issues of importance. Here she is at the Cambodian Dental Association conference, speaking at an FDI meeting in Poland, and receiving an award for the Seal Cambodia project at FDI in 2016. Handing over, well, this picture here is interesting because, as I said, Dr. Solita has demonstrated courage. In 2016, there was a divisive issue over whether dental nurses or dental therapists should be allowed to open their own private dental clinics. The Cambodian Dental Association was strongly against this move, and Dr. Solita was responsible for gathering over 2,000 signatures in a petition and taking it to Parliament to try and overturn a decision allowing private practice for dental nurses. This was risky for her, as it was seen as being critical of the government. However, she stood up for what she believed was right and showed strong leadership. The next leader is Dr. Sher Tepiru from the Ministry of Health. Faced with severe budgetary restrictions and resistance to progressing almost anything on the oral health agenda, she has continued to be a positive influence for over 30 years. Her leadership demonstrates resilience and determination. Some of her achievements include the National Oral Health Survey, analysis of fluoride in water and toothpaste, maternal oral health education programs, school programs, support for a range of important public health research projects, and establishing the first dental nurse school in Cambodia, and helping to run the first dental public health master's course in Cambodia. Now she's working hard to address issues of high sugar consumption, early childhood caries, and water fluoridation. Here are some photos showing Dr. Tepiru in action, establishing the first dental nurses school with a group of the dental nurse students, representing Cambodia at regional meetings, judging at the Cambodian Dental Association Student Research Competition this year, leading school dental health promotion programs. The third leader I would like to highlight today is the present president of the Cambodian Dental Association and Vice Dean of International University Faculty of Dentistry, Dr. Kor Hock Sim. The oldest of 5 children from a working class family, Dr. Hock Sim worked hard at university and after graduation won a scholarship to study oral maxillofacial surgery in Korea. Now she has leadership roles in the Cambodian Dental Association, at IU, and in several dental societies. And she's only 31 years old. So Dr. Hock Sim demonstrates that young people can also be leaders. Here she is at her graduation from Korea, leading staff and students to the IDCMR meeting at Mahidol University, speaking at the Cambodian Dental Association conference. She also started an NGO called the Dynamic Dental Youth Project, which sends dental students out into poor communities to provide basic dental care and give dental health education. So Dr. Kor Hock Sim's focus has been on building the capacity of future generations of dentists in Cambodia. Presently, she's on the local organizing committee as the chairman for the Oral Health Promotion in Schools conference, which will be held in Siem Reap in September this year. The final young woman that I'd like to mention is Ms. Sieng Tida, who was a dental student at my university, at University of Putisastra. Tida comes from a poor family, and she had a job as a dental technician for an NGO before a donor helped her with some sponsorship so she could go to dental school. She's older than other students, but became class leader, and over the last few years has been developing strong leadership skills in research, international exchange, on the Cambodian Dental Association local organizing committee, in her work in prisons and community work. So Tida demonstrates that leadership can start early and is something that can be encouraged and developed. Here is Tida on an exchange program with Khon Kaen University in Thailand, providing oral health education for orphans, presenting research at a dental conference, helping out at the World Oral Health Day, while at the same time maintaining her top placing as in the clinic. Tida loves children and wants to work for an NGO when she graduates. And this is not a common aim of a lot of students who graduate. Now, to keep some sort of balance, I will now present about a charismatic young leader, Dr. Tit Hong Yu, who is one of Cambodia's foremost dental leaders and entrepreneurs. He's the greatest example in Cambodia of an entrepreneurial dental leader who, through his own efforts, has built a world-class dental hospital. Coming from a poor rural family, he developed a passion for learning and a passion to become the best. After graduation, he traveled the world seeking knowledge and skills. And only recently, he completed a master's in implantology from Germany. He now has a range of successful businesses and is the undisputed leader in implants in Cambodia. Let me share with you his most significant achievement, the Rum Chong Dental Hospital. Here it is in this picture. It has 35 dentists, 12 of whom are specialists. It has the latest in equipment, including cone beam CT, CAD-CAM, microscopes for endo, and so on. Here are some of the staff. And it's one of the top dental clinics in Cambodia at the moment. It's got its own well-equipped dental lab. Dr. Tit Hong Yu is a leader with vision, and he demonstrates that with determination, anything is possible. Most people who come to Cambodia are extremely surprised to see a clinic of this standing here in a developing country. So he now serves as the example of excellence in dentistry that other Cambodian dentists can follow. And he's helping to improve standards of care of dentistry in Cambodia. Cambodia desperately needs good dental leaders to tackle a range of urgent oral health issues, including the problem of early childhood caries. In Cambodia, the average 6-year-old has 9 decayed teeth, 3 of which are pulpally involved. We also have the issues of lack of water fluoridation, high sugar consumption, and high tobacco use. We have a lack of school programs for oral health. There are safety issues in dental practice. There are issues related to the quality of dental education and a lack of services for the poor. So what will be the future of oral health in Cambodia? With this new generation of dental leaders, some of whom I've talked about today, the future looks bright. On all fronts, we're seeing young Cambodian leaders stepping up to meet the challenges as women, as educators, as leaders of the dental profession, as leaders in dental public health, as students, as entrepreneurs, and as researchers. What can be done to help develop good leaders? Providing training opportunities and mentoring for dental students to become good leaders. Giving potential leaders international exposure and opportunities for further education. These opportunities are presently very limited. Supporting the dental profession to choose their own good leaders and encourage democratic processes and equal opportunity policies. These will all help to ensure that in the future Cambodia has good leaders. In conclusion, an increasing number of competent dental leaders have emerged in Cambodia in recent years, and they are starting to make positive changes. Many are women, many have higher education, and many are quite young. Dental leaders in Cambodia do face many challenges, but we know that developing leaders can start early, even during the university years. Thank you.
Thank you, Prof. Kalam. That was an excellent presentation. You used a different style in your presentation, wherein you showed us a real example of leaders and showed us the traits of a leader. And it left me worrying a bit that there are no males as the leaders unless you showed us the last example. And then I realized that the person who is identified and thank you, Prof. Kalam. And allow me to go to the next speaker. The next speaker is Dr. Irene. She is from Indonesia, and with the training we had, I think we became friends. And she is currently official title is IMUOHS Consultant in Food Oral Health Program, a senior researcher and faculty of Public Health, University of Indonesia, lecturer at Dental Public Health Department, Mostopo University, regional manager GC for Indonesia and Brunei, founder director of A-Care Foundation. I don't know how you find time to do all these things, Irene. She graduated from Faculty of Dentistry, University of Indonesia in 1995. She then managed school oral health program involving about 10,000 children for about 16 years. In 1996 to 1999, she was involved in IMUOHS ART research in Indonesia. In 1998, she was appointed by Prof. Douglas Bradhall of Malmo University to translate officially Karyogram into Indonesian language. Now you know from where Karyogram came into Indonesia. She finished her PhD at the University of Indonesia and received the Indonesia World Record as the fastest PhD graduate. I should be a bit humbled by this because it took me about 10 years to finish my PhD, whereas I see my friend doing it in 22 months. Our dissertation was about Caries risk simulator for preschool children, developed after vast research involving more than 2,500 children and the parents. She'll be our expert speaker, focusing dental leadership in perspective Indonesia. Over to you, Dr. Irene. Please welcome.
Good afternoon, everyone. I would like to share a bit about the Indonesia. We have big challenges in Indonesia, as you can see here. Our population is very big, 250 million, with 46% living with less than $2 per day. We have dentists and dental nurse, but the ratio is also very big. And we have problems because 6-year-old children, they have more than 7 teeth decay with prevalence of 90%. So in my capacity here, we would like to try some new development of a new concept. We call it dental immunization. The idea here is we do not want to wait until it becomes decay, but we want to prevent it further, and we make 3 phases of preventive actions. And the first one is risk assessment using Iron Donut software. The second is the remineralization therapy if we already found white spot lesions. And the third is the surface protection if we see that there is a progression of the disease. And what unique in this approach is the risk assessment and the remineralization therapy. We modify and use parents and the school teachers and the students to do the activities by themselves. So the health providers can concentrate doing the surface protection and later on ART. So the the energy here is really the empowerment of the community. So what I would like to present today is how this dental immunization result in conjunction with the Global Charter for Public Health that has been presented earlier by Dr. Hee-Won Lee. So the Global Charter for Public Health consists of 7 dimensions with 3 dimensions as the core and 4 enabling factors. So in terms of the promotions, what we want is the change of the behavior. So what we do in dental immunization activities is we change the behavior of Ministry of Education, schoolmasters, parents, and even teachers. Our purpose is to empower community to be able taking preventive measures and change their behavior. And for this, we have the checklist to monitor their knowledge, attitude, and practice. This is the checklist that parents do every day to make sure that they do the activities as advised. And this is the meetings with all the headmasters that we conducted. Still in the promotions, we also want to change the behavior of the students or the children. And we also conduct what we usually do, that is toothbrushing. But here we choose to use triple ID gel. Why? Because as you can see in this picture, this is a picture of a student that's just finished toothbrush activities. And here you can see when I apply the disclosing gels, this is a clever disclosing gel because it can tell the age of the plaque. So if it is pink, it means it's a new plaque. If it is purple like this is a 48 hours plaque that has not been removed. And if it is blue, light blue like this, it means it's a cryogenic plaque, or maybe it's like 5 days. It's not moved by toothbrush. So seeing this picture, it shows that it's very important that child increase their toothbrush skills, not only just toothbrushing activities together. And in the prevention section, we have 3 prevention actions. The primary one is caries risk assessment using Iron Donut software. This is a software that can calculate the risk of having cavities in the future. This is the looks of the software. This software can be downloaded free from the website irondonut.com. So after you fill up the questions, then it will show a donut diagram on how many percent your will be having cavities if you still keep your bad behavior. And in the software, it come up with advice, but what new is also come up with menu. So people like to choose whatever they are capable of. So it's not like one side advice or direction, but they prefer that they can choose what they can do. So after they choose what they want to do, the donut diagram will then do the simulation of how many percent they are getting healthier now. And after that, we can also print the report of the tooth report, which we can show with empathy, and also it can prove the self-efficacy of parents on how to do the preventive actions. And for the secondary prevention, I'm taking these pictures to show that teeth are the strongest part of the human body which can withstand high explosions and are not damaged by such incidents. But in the mouth, teeth can become so weak, and it is because of the acid produced by the bacteria, as we know. And the earliest visible sign that teeth are demineralizing is white spot. So that is why in our dental immunization activities, screening white spot is therefore very important, because this is the first sign that we identify that the patient's having a disease. And what we want is we want to quickly modify the saliva pH and bring back the calcium phosphate or do remineralization to stop the progress of the caries disease. So as you can see, if this is demineralizing and we don't stop, the white spot will soon be like this one. And for the tertiary preventions, as you can see, many of our 6 years old child has permanent teeth, and when they erupted, it's already decaying here and there. So we want to quickly surface protect the erupting molars, and the choice that we choose is GIC because it can be done in the field without electricity and without light curing units. And for us in Indonesia, the cost is only 40 cents for the materials. And not only that, we also do the ART fillings, and we can do the ART fillings here 3 minutes per tooth. We find it very important because it can prevent loss of self-confidence in children. In terms of protections, we also want to regulate the behavior. So that's why we have the students' performance report on their tooth oral health. And we also measure the health impact assessment. We found out that 50% children with decays more than 7 teeth were underweight. We measure that using the dental immunization approach, we got the improvement of healthy lifestyles. We get reduction of drinking soft drink from 47% to 3%, reduction of candies consumption 21% to 2%, reduction of buttermilk usage 18% to 1%. And to protect the continuity of the program, we also involved in international coordinations, and it was senior dental leaders meetings that brought these dental immunization activities up to now and make it a very powerful support for us. This is with Dean of Harvard University, and we have just been able to launch the dental immunization book by his help. In terms of advocacy, we do the social mobilization with primary stakeholders and critical stakeholders that involve the district level, provincial level, and national level of health office and education office. And we also involve school principals and parents for dental immunization activities. Still in advocacy, we also have voluntary community engagement with the characteristic of self-reliance. This is happen in big city like Jakarta, and this happens in another remote cities that is very low income. But those shows that they have their own way to show that they want to participate. In terms of information, we do have the monitoring evaluations in family level, school level, health district level, and even have district education office. And up to now, we have more than 200 schools with more than 20,000 children that participating in dental immunization programs. We also have the measurement on the teeth itself. The percentage decay of permanent teeth has been reduced within 6 months after implementing the dental immunization program. And the percentage of caries-free children has been increased within 6 months of implementation of this program. In terms of risk and innovations, we teach the schools and the children that drinking milk using bottles is carries risk for the children. So understand the situation. The teacher of the school then have an innovation. They make bottle milk graduations. So every child has to surrender their bottles, and the teacher will exchange with the glasses. And even they are able to make the bottles into education materials like bees, like cars, and etc. In terms of capacity, we built up health workers and using wider workforce such as dental nurses, teachers, headmasters, and parents. This is a dental nurse, and she is able to conduct the dental immunizations programs in many schools by herself. This is parents. We involve parents to apply the disclosing gels in the schools. This is teachers. She is teaching the Iron Donut software, but because they don't have laptops, they make their own flip charts. And this is the headmaster and the dentist planning for the dental immunization activities. To build up the capacity, we also do teachings, and we have the training modules for dentists like this, because for some dentists, the program and the program inside the dental immunization is also very new. We try to put it in curriculum. So we have now the book of dental immunizations, also written by Dean from Harvard University. And we make it the curriculum for dental nurses, for teachers, and for parents. And the reason why we make the book in English, because there is a request from many countries for us to make the book so it can be applied at international level. We also understand that in terms of governance, it is better that for an activity it's put in the governor regulations to make sure the sustainability. So dental immunization has been put in the Ministry of Health regulations and also in manuals. We also do the health and cross-sector policies. We make MOUs between Ministry of Health and Ministry of Education from the locals up to the governments. And lastly, in terms of financing, we choose to do autopoiesis or self-financing with average of 50 cents to $1 US dollar per child per month. We are able to do the self-finance of the whole programs. And why we choose self-financing is because we want to have the community ownership. Because if you have community ownership, then our program will sustain. So different with other programs, we do not want to rely on sponsorships. We do not want to rely on companies, because if we rely on the companies, then if they stop the financing, then the program might stop. So we choose the self-financing one. We still have our future dreams. And we hope that the dental immunization will soon be covered by the universal health coverage in Indonesia. So dental nurse and dentists who do the dental immunization will also get paid by the government. I'm already finished the presentation as the summary. The dental immunization is a new concept for integrating oral to whole body disease approach. It's a people's health of self-perpetuating system. We still need international supports and collaborations to implement this concept within multi-center approach in several countries. For those who interested to implement, you can contact us after the session to get the books. Thank you very much.
Irene, it was good, organization fits into a dental public health forum, but you helped us understand.
No, I agree with what Prof. Rahima and Prof. Allen have said. I think everybody does have a role to play, and we can often play that through organizations, through organized groups. But it's essential that we have leaders who are able to advocate on behalf of oral health, dentistry, the profession, and so on, and advocate at the high level. And that's where I think leadership training and helping give our leaders the skills that they need to be able to advocate well is very important. Just going back to the entrepreneur comment by Prof. Allen, although, as Prof. Rahima said, among our students, there are a range of activities that we can involve them in and put them in leadership positions while they're students, and in trying to encourage them to develop those skills. At our dental school, we don't really have anything formal to help them do that. I don't know about other dental schools. The Global Child Dental Fund has their program for young leaders, but I wonder if anybody else, or maybe at IMU, do you have something to help develop the leaders in some sort of formal way? Thank you.
Hi.
Normally we have, but we have Prof. Alan, Prof. Rahima with us. So bye. Thank you, everyone. Bye.